Hello, this is Dr. Sargisian, and today we'll talk about genetics in pediatrics. This is one of the lectures in series of genetics in pediatrics, and today we'll talk about sickle cell disease. And this is our topics in genetics in pediatrics series, and we will talk about the topic of sickle cell disease in the view of analyzing the relationship between genetics and particular diseases, as well as facilitating the integration of genetics and genomics in pediatrics primary care practice. So this disease belongs to monogenic diseases or disorders. It's a single gene trait, and the single gene controls the expression of specific structure, protein, or function. And also the transmission patterns will be either autosomal dominant, autosomal recessive, or sex-linked pattern. So in this case, it's autosomal recessive transmission. So sickle cell disease is a disorder, is a genetic disorder that caused by a single nucleotide polymorphism, basically point mutation in both alleles of a single gene. So what it does, it leads to the formation of the beta chain abnormally, and beta chain, of course, it's a beta chain of hemoglobin or beta globulin. This disorder is transmitted by autosomal recessive pattern, and it's most commonly seen in people with African or Ecuadorial descent from Africa, and basically people whose ancestors were from areas near equator in Africa. So among African Americans in United States, sickle cell disease occurs approximately in 1 in 400 to 500 live births. So approximately 90 to 100,000 people living in North America have this disease. So also people may have sickle cell trait. Trait, of course, is a situation when the person has only one mutated allele, and in this situation, one mutated globulin gene allele, and it can happen in 1 in 15 African Americans in the United States. So in Africa, sickle cell disease and sickle cell trait have been seen in Eastern Africa and also in the majority of Equatorial countries. It's the prevalence of it and incidence in these countries is much higher than in other regions of Africa. So what genetic makeup contributes to this disorder? So transcription and translation of the beta globulin gene related to production of certain amino acid proteins in glutamic acids. And in classic form of sickle cell disease, both beta globulin alleles have mutation in which DNA triplet coding for glutamic acid has substitution of original thymine alleles, and it has adenine substitution. So this mutation leads to valine, a 6 amino acid in the protein sequence. So uh, because of that, the hemoglobin is abnormal, and this is called hemoglobin S compared to normal hemoglobin, which is normal adult hemoglobin, to be precise, which is hemoglobin A. So, of course, when the both alleles of globulin gene are mutated, then lots and lots hemoglobin S occurs in the red blood cell instead of common hemoglobin A. So hemoglobin A, as you remember, it attaches to oxygen, and actually you remember that the chains attach to 4 molecules of oxygen, same way as hemoglobin A, hemoglobin S can attach to the oxygen. So that said, you may say, so what's the really issue here? The issue is that, unfortunately, the association with oxygen, or when the globulin molecules, the chains attach, the chains start tightening. So basically, the hemoglobin S is very sensitive to low levels of oxygen in the tissues. And these chains are folding. I said tightening, but we can also use the word folding. So this leads that the chains are pulling the red blood cell inside and giving it this sickle cell, where the name of the disease, of course, coming from. So again, like I said, there is high percentage of hemoglobin S, and again, like I said, they carry oxygen the same way, but again, hemoglobin S can lead to different shape of the blood cell, and basically sickle shape, and it will lead to several problems when the red blood cells are in this shape. Okay, so the cell membranes will be pulled inward and take the sickle cell shape. So when this happens, the sickle cells, they aggregate together and they block the blood flow. Tissues that are distal to the blockage, they are receiving very poor perfusion or no perfusion at all, and poor oxygenation. When these tissues have poor oxygenation, it cascades to another level because sickle cells sense it, and more clumping occurs. Also, these cells are not really stable. They have, as you remember, normal blood cells with hemoglobin A live approximately 120 days, but these cells live only 16 to 20 days. So there are issues that the replenishment may not happen. And another name for sickle cell disease is sickle cell anemia, because patient may present with anemia just with because of the problem with the renewal or replenishment of these cells. Okay, so inheritance patterns in sickle cells anemia are rather straightforward. There is very low incidence of spontaneous development. So it is, like I said, it's autosomal recessive pattern, and people with allele, with an abnormal allele, with one abnormal allele would be carrier, but when two carriers produce an offspring, there is a chance, obviously you remember Punnett square, there is a 50% chance that the offspring will have the disease manifestation. So person who has sickle cell disease, they will have 80 to 90% of their proteins or of their hemoglobin replaced by hemoglobin S. Hemoglobin A, instead of hemoglobin A, they will have hemoglobin S, which, as we already mentioned, can be replaced or can be clumping much easier and have sickle shape, and by reacting to low oxygen level it can cause clumping of the cells and leading to more and more hypoxia in the tissues. So signs and symptoms of sickle cell disease is the consequence of poor perfusion and oxygenation of body tissues. This leads to pain, overall disability, organ damage, occurrence of infections, and unfortunately to early death. Because the red blood cells have short lifespan, as I said, instead of 120 days, it's approximately 16 to 20 days, then patient will have chronic anemia, but it's interesting that these patients will not be iron deficient. Okay. And it's interesting that if you do order if you do order blood transfusion to a person with red blood, uh, sickle cell disease, the transfusion may lead to iron overload. So the special considerations should be taken not to lead to iron overload. Okay. So signs and symptoms occur from conditions that can trigger hypoxia or poor blood flow, and they will lead to sickling. So these conditions are dehydration, infection, if the blood stays in veins too long, or venous stasis, drinking alcohol, of course, being at high altitude, low temperature, like low cold environment, or cooling body too much, exercise, like very rigorous strenuous exercise, pregnancy, and even anesthesia. So when patient develops sickling, and another name for it, sickle cell crisis. During the sickle cell crisis, extensive sickling will occur and will disturb the blood flow to organs or body areas, and because of the hypoxia, patient may develop significant pain, and this is like the hallmark of the actual sickle cell crisis. Uh, So when the oxygen level are coming back to normal, some of the sickled cells will resume the normal shape, while others will remain sickled. And at the same time, they will be more fragile cells that didn't recover, and the fragile cells can trigger even more sickling. And more sickling can be triggered by just very, very low, very, very small fluctuation in tissue oxygen levels, which will be very insignificant for people without this abnormal hemoglobin S. So over time, because patient has repeated blood vessel clogging or blockage, this may lead to hypoxic damage to lots of tissues and organs, basically everything you can think about. Especially these are organs that highly dependent on oxygen, and these organs are liver, kidneys, brain, spleen, bones. And the hypoxic tissues will become anoxic and ischemic, and basically repeated hypoxia may lead to necrosis. So the organ doesn't die immediately, but small necrotic points or spots will appear first, and then these areas become fibrotic, and then organ will lose function. So these areas grow in an organ, and then scarring will also occur, and then organs quit functioning. Okay. So disease severity and complications vary among different people with sickle cell disease, and children who receive supportive care for sickle cell disease, they live into adulthood, but complication of disease unfortunately only can be delayed with modern development of medicine, but they are inevitable. The only cure for sickle cell disease is a stem cell transplant. And again, while this is promising, and this is really the cure for sickle cell disease, there are many serious complications that can occur with stem cell transplant, and it is also very expensive. So still there are not many instances of using stem cell transplant. But again, you may say that the cure exists, and it will be via stem cell transplant. Okay, so how sickle cell disease expressed? Again, like I previously mentioned, there is a high disease variability. It may be mild or severe, and the predictor how the sickle cell disease will develop is the fetal hemoglobin, HbF. Fetal hemoglobin that remained in adult circulation, or the quantity of that, can predict that how severe will be the symptoms. Everyone has HbF during the fetal stages, of course, during fetal life, and the reason for the existence of fetal hemoglobin is that the oxygen is delivered like from maternal circulation. So the baby will be receiving, doesn't use obviously their own lungs to maintain the oxygenation, but they're receiving oxygen like in a secondary way from the mother. So that's why the fetal hemoglobin can tolerate low oxygen levels, and it will not, like normal adult hemoglobin, it will not be sickling. But when the baby is born, the adult hemoglobin will replace most of the fetal hemoglobin, and eventually people will have very little of the fetal hemoglobin. So it's approximately 2% will be left, and the rest of the hemoglobin will be adult hemoglobin. However, in patients with sickle cell disease, it's possible to have as much as 20% of fetal hemoglobin through their adult life. So the more fetal hemoglobin they have, the milder will be sickle cell disease. Uh, Nobody really knows why hemoglobin F or fetal hemoglobin is present in this patient, but speculations are that this is genetically related or genetically relevant to this patient. However, there is no genetic makeup or no genes identified that actually responsible for this action. So the treatment for sickle cell disease again includes stem cell transplant, and we talked about pros and cons of it before, but also there is a pharmaceutical treatment. Hydroxyurea can actually increase the percentage of hemoglobin F in some people, and it can be a long-term therapy. And hydroxyurea can lead to increased level of hemoglobin, of fetal hemoglobin, and this way the complications of sickle cell disease will be delayed. At the same time, unfortunately, not all people will respond to hydroxyurea, and the magnitude of the response or the strength of the response is not well understood. And at the same time, hydroxyurea has multiple side effects, and one of the most concerning ones is the risk for development of certain cancers. There's a newly developed drug, relatively new, it's Endari. Endari is working on replenishing the amount of glutamine, or technically it is an amino acid glutamine, and which is given orally twice daily. Again, the exact mechanism is not well known, but the school of thought on it that the glutamine will reduce the oxidative stress within red blood cells. Basically, the red blood cells, even with sickling tendencies or with hemoglobin S, will be less susceptible to low oxygen level in the tissues. So patients who take this drug will develop red blood cells that live longer instead of 16-20 days. Typical of sickle cell, they may live almost the actual lifespan of the red blood cells. And again, they will have less sickling, and which will reduce the complications of the disease. And this is concluding the sickle cell disease segment of this lecture series.